Thank you for the introduction and the opportunity. So a couple of authors have conflicts of interest to disclose. So cryoablation is increasingly used for analgesia during the Nuss procedure for repair of pectus excavatum. Using a thoracoscopic probe, extremely cold temperature is applied to intercostal nerves to temporarily disrupt nerve function, including sensation. Existing studies demonstrate that cryo decreases opioid requirement and hospital length of stay. In our study, we sought to evaluate our clinical outcomes over our 3.5 years experience of performing cryoablation in the Nuss procedure. We performed a retrospective chart review from December 2017 to August 2021. We looked at all of our cryoablation patients and compared them to those who received subpleural on-cue elastomeric pain pumps. We also looked at our fourth quarter most recent cryo patients and compared them to the first quarter patients to investigate changes as our experience with the technique increased. Data regarding demographics, hospital course, and postoperative complications were collected. In total, we performed 383 Nuss procedures by 8 different surgeons. 350 patients received cryoablation and 33 received the on-cue pain pumps. There was no difference in age, BMI, and pectus excavatum severity as indicated by the Howler and correction indices between all treatment groups. Over time operatively, we increased the number of nerves cryoablated, and most recently, a Nuss procedure with cryoablation takes approximately 2 hours to complete. In their post-operative course, when we look at our total cryo patients and compare them to the on-cue patients, the cryo patients use significantly less opioid in hospital and on discharge. Fewer cryo patients used a PCA in hospital, and they were discharged over 1 day earlier. I should note here that opioids are expressed in oral morphine equivalent. When we compare our fourth most recent quarter cryo patients to our first quarter patients, there was a significant difference noted in all domains. The fourth quarter patients used 74% less opioid in hospital and 21% less on discharge. Only 26% of the fourth quarter patients used a PCA in hospital, and they were also discharged more than 1 day earlier. When we look at length of stay as a proportion of patients remaining in hospital on each post-operative day, there's a clear trend of earlier discharge over time, from our on-cue patients shown in gray to our first quarter cryo patients in orange to our most recent fourth quarter patients in blue. And then in that most recent group, 80% are discharged by post-operative day number 2. Given this improvement in outcomes, we looked at our complications as well. Comparing the total 350 cryo group to the on-cue group, there was no difference in 90-day readmission or wound infection, chest tube placement, gabapentin use as a surrogate marker for neuropathic pain, and bar migration requiring reoperation. And this holds true when we compare our fourth and first quarter cryo patients as well. On multivariate analysis, cryoablation quarter, PCA use, female sex, and correction index were significantly associated with decreased inpatient opioid use. Cryoablation quarter, PCA use, and inpatient opioid use were significantly associated with decreased length of stay. However, we did find that the number of nerves cryoablated was not significantly associated with either inpatient opioid use or length of stay. So overall, in this study, we've demonstrated an improvement in outcomes in patients undergoing cryo with the Nuss procedure over time. And with this, we made some practice changes. In our fourth quarter, we eliminated the routine use of PCA, and this had a significant effect on decreased inpatient opioid use and hospital length of stay. We also increased the total number of nerves cryoablated, but this appears to be of lesser importance, and the net result was earlier discharge home. We also did not note a significantly increased rate of bar migration requiring reoperation, and we think that this might be due to our pericostal bar technique or bar fixation technique using fiber wire. I should acknowledge some limitations of the study that includes its retrospective nature. Our discharge opioid prescription amount does not reflect the actual use, and gabapentin was used as a surrogate marker for neuropathic pain here, but we don't have sensory documentation at this time to corroborate this. So in conclusion, in our experience, cryoablation is safe and effective for post-operative pain control in the Nuss procedure. Cryo decreased opioid use and hospital length of stay while permitting the elimination of routine PCA use with low rates of major complications. I'd like to thank the surgeons and the PA of the Chest Wall Center for their collaboration and their work. And thank you guys for listening, and I welcome any questions and discussion at this time.
Hi, Stephen Lee, UCLA. Great presentation, great study, really nice experience. I'm interested in your longer-term not complications, but problems with cryo. We've noticed some significant skin discoloration. I don't know if you've seen that. And speaking with the actual company, they actually claim that shouldn't happen. And then the second thing is, how long typically does the sensation last before they get it fully back? And then have you seen any chronic neuropathic pain like more than a year? Thank you very much.
Thank you for that question. These are certainly points we've thought about as well. So to address point one in terms of skin discoloration, we have not, in my recollection of these patients' charts that I reviewed, there was no incidence of skin discoloration or skin issues similar to that sort that we were able to document on follow-up. The second question was, I believe, return of sensation. And at this point, we haven't noticed any long-term neuropathic pain issues or permanent loss of sensation. Usually we see sensation return within about 2 to 6 months. We are currently doing a study to actively assess that, where we test the children's sensation at the time of bar removal, because now we're over 3 years out of our first cryo patients. So hopefully we can offer some insight into that in a future meeting.
Thanks very much. Mike Livingston, McMaster Children's Hospital. Just wondering if you could comment on the upfront and then ongoing costs associated with this technology. Our group, myself included, doesn't use this device, but we're very interested. But in the Canadian context, we sometimes have to do a lot to justify costs, so wondering if you could discuss that.
I don't have all the information to probably provide you with a great answer for that, because a lot of the cost has to do with insurance, and that is between the insurance company and the patients. But what I do know is that any significant cost increase is borne out by the patient.
We have another question.
Thank you, Sharif Emile, Montreal. Thanks for sharing this. I think it's probably one of the largest experiences. So we're switching to cryo next month, and in trying to make the decision, a lot of the reluctance was regarding this long-term neuralgia. So I know you don't have that data, as Steve mentioned, but I do think we need to monitor that, because that's something that potentially could come back and haunt us. The early results are obviously very good, but I don't think we have enough information yet about very late results. I was interested in the last point you made about fixing the bar using pericostal sutures. I mean, I do that routinely, but are you finding that maybe cryo leads to more dislodgement because patients are moving more or moving faster or actually more comfortable, or how are the two related?
So in this cohort of 350 cryo patients, we did not notice a significant increase in bar displacement rates requiring reoperation. And we postulated that to make up for the children's increased comfort with movement, it would be that our pericostal bar fixation technique at 2 separate points in the bar and at 2 separate ribs, one laterally at the eyelet on one rib and one anteromedially at the point of swing at a different rib.
Okay, thank you.
Thank you.
Thank you.
Thanks very much.
Thank you.